Hello, everyone. Welcome to the second lecture, Chapter 2, Understanding and Treating Mental Disorders. In this lecture, we will take a look at the one-dimensional model of mental disorder, the multi-path model of mental disorders. We will look at resilience. We'll take a look at all of those different dimensions, biological, psychological, social, and sociocultural, and we will end with a discussion about contemporary trends and future directions. The one-dimensional model of mental disorders. What is a model? A model attempts to describe a phenomenon that cannot be directly observed. Models are intrinsically limited and cannot explain every aspect of a disorder because human disorders and human behaviors are very complex. One-dimensional models of mental disorders include the four following. So there would be the biological model, which would look at biological dysfunction that causes difficulties, and the biological model would be interested in things such as genetic predisposition. There's the psychological model that focuses on early childhood experiences and irrational beliefs and other psychological concepts. There's the social model that looks at social relational perspectives and family and other social influence. And then there's the sociocultural model that takes a look at societal and cultural context that influences behavior. The biopsychosocial model, you may have heard about this in other courses or maybe in your work. And the biopsychosocial model highlights the fact that there is the interaction between biological, psychological, and social factors that leads to or contributes to mental health disorders. There are some limitations with this model in that it does not focus on how these factors interact to produce illness, and it provides less guidance about treatment, and the authors suggest that it neglects the influence of culture. So the authors offer a more useful multi-path model. The multi-path model considers a multitude of factors research have confirmed that are associated with each other. And some of the assumptions of the multi-path model include that not all of the dimensions contribute equally, and it is important to note that there are multiple pathways and multiple influences that might contribute to the development of any single or multiple disorders. The multipath model takes a look at the biological dimension, the psychological dimension, the social dimension, and adds the social and cultural dimension that is not included in the biopsychosocial model. You'll see that this diagram and these arrows really emphasize the interconnected nature of how these different dimensions influence one another. Now we're going to take a look at resilience. Resilience is our ability to recover from stress and adversity. I have a picture of Tigger on here because I always think about Tigger when I think about resilience. I think about resilience is about our ability to bounce back, right? So we might have these really difficult life experiences. Maybe you guys have heard about adverse childhood experiences or ACEs that are really influential to how our wellness, both our mental wellness, but also our physical wellness later in life. But the counterbalance to those adverse childhood experiences or to really any difficult life experiences, even in adulthood, is this idea about resilience. And it's about our ability to bounce back from stress or adversity. And resilience is about protective factors, so conditions or attributes that lessen or eliminate the risk for negative psychological, social, or physical outcomes. And the resilience model really emphasized the importance of looking at strengths, assets, and protective factors to help maximize and support our mental health. Embedded a quick video about resilience. You may have already watched this video because I also posted it under the week 1 outline in Moodle. If you haven't had a chance to watch this video yet, go ahead and take a minute to pause this lecture, watch the resilience video, and then come back to the rest of the lecture. Now we're going to take a look at the individual dimensions. We're going to start with dimension 1, the biological factors that influence mental health. Our text talks pretty in depth about the human brain, and I want to let you guys know that I really only am hoping that you'll take away the highlights um, from this chapter. And so that includes just having an understanding of how the human brain has these different parts that are responsible for different functions. So the forebrain that is responsible for that higher level executive functioning, the midbrain that does more of our basic functioning, temperature regulation or sleep-wake cycles, and then the hindbrain that is the most primitive, instinctual part of our brain that's responsible for our survival, for the flight, fight, freeze response, and for breathing and digestion. And also on here about the brain, I have about our limbic system. And so I think understanding the basic brain structure and understanding the limbic system is really important for anybody who is doing work in psychology or in the mental health field. And some of you I know are neuroscience majors and maybe nursing majors, and maybe you guys have dug a little bit deeper into brain anatomy and brain functioning. Um, and that's great. But for this class, we're just really looking at that basic understanding of these different structures. So what we want to know for this class is that when we hear limbic system, we want to be able to recall that these are some of the key elements and features included in the limbic system, some of the key structures in the limbic system. And the limbic system is a part of that deep brain structure that is responsible and associated with emotions, decision making, and the formation of memories. Multipath implications. So as it relates to the biological dimension, biological explanations alone are one-dimensional and linear. Science is increasingly rejecting the idea of one gene for one disease. And what's more accepted is the diathesis stress theory. This is going to be really important for us to know in this course, is that the diathesis stress theory hypothesizes that people do not inherit a specific gene or a particular abnormality, but rather a predisposition to develop an illness. And so when we're talking about a predisposition to develop an illness, we're saying that one person may be more likely to develop an illness than this other person. They maybe have more genetic predisposition or more risk factor to develop an illness, but depending on life stressors, environmental factors, that predisposition may be activated or it may not be activated, resulting in how they experience their mental health. Our text also takes a look at the biochemical processes within the brain. I'm not going to go over this in depth, and you won't be required to know much about the biochemical processes within the brain for our exam. However, if it is something that is interesting to you, the text does a really good job of offering basic descriptions and understandings, and it is important for understanding how psychopharmacology works, and it just is outside of the scope of this class. Something that is important to note is this concept of neuroplasticity, and this is really cool as it relates to working with individuals and treating individuals for mental health disorders. Is we know that neuroplasticity exists, and it is the concept that allows the brain the ability to evolve and adapt and change based on environmental circumstances, and that we have the ability to have new neurons created, and that chronic stress results in negative changes in brain activity. And if we know that chronic stress results in negative changes in brain activity, we will want to work really hard to avoid and provide psychoeducation about that influence of chronic stress. And we can provide some hope about making new connections to reverse some of the impact of the chronic stress as well, because of this concept of neuroplasticity and the ability for the brain to make new connections and new adaptations. So, when I'm working with clients, oftentimes if I'm providing some brief psychoeducation about the brain, I want to be able to provide some brief information about the basic anatomy of the brain, the different sections of the brain and what they're responsible for and how they interact. Sometimes, especially with kiddos, I'll use the hand model of the brain, and we can talk about that a little bit more in class as well. But I also talk about this idea of neuroplasticity, and I talk about what fires together wires together. So when we're in chronic and toxic stress, what fires together wires together, and it oftentimes becomes these unhelpful changes and these changes that don't serve us as well. And at the same time, if we make some modifications, what fires together wires together, and we can make more positive changes in how our brains are working. Some biology-based treatment techniques. Our text talks about psychopharmacology and different medication categories. Definitely that falls into that biology dimension. And there are some other treatment implications as far as how we discuss psychoeducation with patients or clients, just as I talked about, and how our knowledge about biology and neuroscience influences how we treat individuals and how we are with individuals. And there are a lot of therapeutic approaches that are very much influenced by how we understand how the brain works. Some criticisms of the biological models and therapies is that sometimes they fail to consider the individual's unique circumstances. There is a rapid growth in the sale and marketing of psychotropic medications, and there are many drug-drug interactions possible for individuals who are prescribed multiple psychotropic medications. And we also are still learning so much in the field of psychopharmacology, and so there's more to know than more that we don't know than there is that we know. And that is important to take into consideration when it comes to psychopharmacology as an intervention. Dimension 2, psychological factors. So 4 major perspectives: psychodynamic, behavioral, cognitive, and humanistic or existential. Psychodynamic is really, we're looking at Freud's psychoanalysis and how he looks at the id, ego, and superego. We're not going to dive super in depth into these different models, but it's just important to know that these are some of the most influential models for the psychological factors. More contemporary psychodynamic theories include Adler and Erikson and Bowlby. Really, that idea about attachment comes out in Bowlby's work, and how childhood attachment influences even adult behavior. Therapies based on psychodynamic model include psychoanalysis or interpersonal therapy, and many other therapies do have influences from this initial model of psychology. Some criticisms is the failure to address cultural and social influences, not as many outcome studies as compared to other models, especially the behavioral model, and that it may not be useful with all populations. The behavioral model is concerned with the role of learning and development of mental disorders based on experimental research, and really looks at the 3 paradigms of classical conditioning, operant conditioning, and observational learning. Some behavioral therapies include exposure therapy or gradual exposure therapy, social skills training, and some criticisms are that this type of approach may often neglect inner determinants of behavior and is more so just looking surface level behavior. Some cognitive behavioral models focus on observable behaviors, so how thoughts influence emotions and behavior. Beck and Ellis were really influential as it relates to cognitive behavioral models. There's the ABC theory of emotional disturbance, so A is the event, and C is the person's reaction, and B are the beliefs about A, which influence or cause the reaction C. And then the third wave of cognitive behavioral therapies includes mindfulness, dialectical behavioral therapy, and acceptance and commitment therapy. Some criticisms is that it's all about observable behavior and cognitions are not observable, and there is more of an authority role of the therapist in some of these models, and that power dynamic may be intimidating to some clients. The humanistic models. So quick look at humanistic models. Really big here is Carl Rogers and that person-centered approach and the basic assumption that humans are good and are trying their hardest and they are trustworthy, and there's this inherent tendency to strive toward one's full potential. The existential perspective looks at a set of attitudes in the context of the human condition. A humanistic approach would be person-centered therapy, and an existential approach would be existential therapy, which is rooted in philosophy and universal challenges of humanity. Some criticisms is that it can be very ambiguous, that it relies on an individual's unique and subjective experience, that it does not explain many mental health disorders, and does not specifically address cultural or social factors. Before we jump in with Dimension 3, the social factor, I will just note that if you have specific questions or interest in any of those perspectives of the psychological factors, just let me know. I could direct you to more resources, but you will likely also have other classes that dive a bit deeper into those perspectives and those approaches, especially if you are in psychology or if you're looking toward going more into a track of a mental health professional. But more in-depth explanation would be beyond the scope of this class. So Dimension 3, social factors, it looks at social relational models. Healthy relationships are really important for human development and social functioning. And when relationships are dysfunctional or absent, individuals are more vulnerable to mental distress. There's the family systems model, conjoint family therapeutic approach, strategic family approaches, and structural family approaches within this model. There is couples therapy and group therapy. And group therapy is really commonly used in the therapeutic world. It helps to increase access for lots of individuals. One provider can meet with multiple individuals in a short period of time, and there is a lot of research about how the group members can influence other group members to promote positive change within that group therapy model. Some criticisms of the social relational models include that studies have generally not been very rigorous in design, especially as it relates to comparing to the behavioral dimension. There is just a ton of research, and the behavioral model just lends itself to outcomes research just by the type of approach that it is, versus some of these other dimensions are a bit more complicated to research, especially with experimental designs. Cultural diversity is not adequately addressed, and family systems models may have negative consequences. So it talks about how parental influence may not be a factor in an individual's disorder, but then how the parents might be influenced by that family interaction, and their guilt may be increased. My experience with family work is that more often than not, it is useful. And there's a piece of interconnectedness, and that as one person's wellness and health increases, that influences the whole system. So it's kind of that idea of like a baby's mobile hanging over their crib. You know, when one piece of it is kind of wonky and out of line, then the whole thing moves. But if you move one of those pieces back into place, then it all can fall back into balance. And that's really that underlying belief of family and couples work. Dimension 4, sociocultural factors. So this emphasizes the importance of several factors in explaining mental health or mental disorders. Looks at race, ethnicity, gender, sexual orientation, religious preference, socioeconomic status, and other factors. Looks at gender factors, so higher prevalence of depression and eating disorders among women. Women are subjected to more stress than men, largely due to societal roles. And this may also be important to look at as it relates to individuals who feel comfortable reporting these symptoms, or how treatment providers perceive the symptoms that are reported to them. And so there might be some societal or cultural factors influencing how a treatment provider may be more likely to diagnose a woman or a girl with depression or an eating disorders, and maybe would be more likely to diagnose a man or a boy who may also meet criteria for depression or an eating disorder, but they may see it through a different lens because of societal and cultural factors. And so oftentimes this presents when girls feel more comfortable in vocalizing their feelings, and boys, because of societal norms, feel more comfortable in externalizing those behaviors, and they maybe then end up with a different diagnosis than depression. Socioeconomic class. Lower socioeconomic class is associated with a less sense of personal control or agency, poorer physical health, and higher incidence of depression. Life in poverty subjects people to multiple stressors, and it becomes that idea of there's this constant striving for survival, and there maybe is more chronic stress or more toxic stress, which then impacts both physical and mental health. Immigration and acculturative stress talks about associated challenges of moving to a new country, the loss of social support, the need to adapt to so many different changes as it relates to culture and language and education and employment, and is most common, the acculturative stress is most common among first-generation immigrants and their children. Race and ethnicity. So our text talks about two early models, the inferiority model and the deficit model. I think it's really important to take note about these models because it influences how we see diversity in a historical context. So the inferiority model was that minority groups are inferior to the majority population, and the deficit model was that minority groups lacked the right culture. You know, that there was this idea of the right culture, that the majority population had fit the right culture, and the minority groups lacked the right culture. There is the multicultural model, which emerged in the 1980s and 1990s, where being culturally different does not mean that somebody is deviant or pathological or inferior. And so moving away from that over pathologizing due to cultural or societal differences. And that sociocultural conditions and treatment, the therapist needs to be very careful not to assume that the patient or client shares traits common to the group. And so that it is important to learn about cultural norms and different cultural groups. And at the same time, it's important not to assume that any individual has the same experience of others within that group. Some criticisms of the multicultural model and related therapeutic techniques. Critics see a disorder as a disorder, so regardless of culture, and that's kind of that idea of cultural universality that we talked about earlier. And this specifically can come up with the symptom of a hallucination. So the idea that a hallucination is always something that's undesirable. However, in some cultures, hallucinations can be seen as a gift or as a spiritual connection and is not looked at as pathology. Other criticism is that it relies heavily on case studies and questions are asked based on a Western worldview. Contemporary trends and future directions. So all of these different dimensions and perspectives have strengths and weaknesses. Evidence-based understanding of mental health disorders has evolved and is continuing to evolve. The diathesis stress theory is going to be really, really important to keep in mind and will be something that we come back to throughout this course. And that is the idea that individuals have a predisposition to develop an illness and that predisposition may be inherited, but it does not, it's more of a risk factor than it is a causal relationship to developing the mental health disorder, because there are many other factors that come into consideration. And cultural neuroscience. So future direction and future trend is this idea of and the study of cultural neuroscience, which is the study of how culture shapes biology and how biology shapes culture. And so the bidirectional nature of that relationship. Chapter 2, reflection and review. We made it through the end of the second lecture. And I'm not going to read you these questions, but this is a time where you can end and you can pause on this slide, take a look at the questions, jot some notes down, or just have some time for reflecting on these questions and the content of the second lecture. Thanks so much, guys. I'll see you for the next one.